Hello. Hello, is everyone able to hear me now?
Yes, Dr. Ayman, we can hear you perfectly well.
Oh, okay. Thank you so much. So, hello, my name is Ayman. I'm your colleague today in today's lecture. We are going to cover some topics in psychiatry part today. The first topic we are going to discuss is psychosis. And the term psychosis was used in the past to describe many different diseases, but it's now mainly for schizophrenia. And before we start talking about schizophrenia, we need to remember some points about how our brain works, because this will make it easier for us to understand how the disease happens and how we can control it by using medications. So the neurotransmitter involved in developing schizophrenia is dopamine. Sometimes we call it like pleasure hormone. So this is our brain. And we have four main pathways that are involved in developing schizophrenia. The first
Excuse me, Dr. Ayman, are you sharing anything? Because we see only a file.
What do you mean by a file? Sorry.
I see only psychoconverted and PEBC MCQ psychosis. I see your folders. Are you sharing any slides or anything?
Yeah, it doesn't appear there. I'm sorry.
No.
Let me try again. There now?
Yep.
So you see the slides now?
Yes, we do. If you could just close the right pane. Okay, no problem. في عندك export PDF, edit PDF, create PDF, بس if you can close it. في سهم هيك صغير رايح على اليمين, as I showed you in the video. If you can't, no problem. Just proceed.
Okay, so is the slide clear now?
Yes, everything is clear, but Shams, I put you like an co-animator now, so you can like to measure.
Yes, okay. Thank you so much.
Both of you
Okay.
are animated.
We were talking about schizophrenia. And first, we would like to know the hormone involved in developing schizophrenia. This hormone or this neurotransmitter is dopamine. This dopamine, sometimes we call it pleasure hormone. And this dopamine has four main pathways in our brain that contribute to the development of schizophrenia. As we see here, the blue one is the Mesolimbic Pathway. So what happens when dopamine is high in the Mesolimbic Pathway? It leads to appearance of what we call positive symptoms of schizophrenia. So when dopamine is high in the Mesolimbic Pathway, it leads to appearance of positive symptoms of schizophrenia. So the word positive means presence. Like there are some symptoms that are present. Like what? Like delusions. Delusions is like illogic thoughts. For example, one of the most common examples for schizophrenic patients is that someone thinks him or herself is so smart, and FBI or CIA are following him or her because they would like to steal their magnificent ideas. This is delusion, like illogic thought. The other thing is hallucination. Hallucination is that the patient might feel or see something that is not there. He tells you like, I'm hearing sounds around me, although there is nothing. So these are hallucinations, or I see a ghost, I see something there. Nothing is there, but because the patient has higher level of dopamine in the Mesolimbic pathway, he or she has this kind of hallucination. So these are the positive symptoms. Something is there, positive. On the other hand, the deficiency of dopamine in the mesocortical pathway, which is the red one, leads to what we see here, like depressed patient or low mood person. So we call it negative symptoms. Negative means nothing there, like he feel down, he feel depressed, no desire to work, no desire to socialize with anyone. So the increase of dopamine in mesolimbic contribute to the appearance of positive symptoms, and deficiency of dopamine in the mesocortical pathway leads to the negative symptoms, which almost like depression and low mood. Moreover, there is dopamine in the green one, nigrostriatal pathway. So if dopamine is less in this pathway, it leads to dystonia, which is involuntary muscle contraction. But if the dopamine is high here, it leads to hyperactive movement like tics, dyskinesia. Dyskinesia, we find the person is like dancing. And person is moving quickly like dancing movements. The fourth pathway is Infundibular Pathway. And this one is mainly associated with prolactin. So dopamine itself inhibits the prolactin. So if we are talking about schizophrenic patients, which has high level of dopamine, what will happen to prolactin? Prolactin level will be low. So prolactin is what? It is the hormone responsible for milk production in women, and also it has a role in sexual function. This is why schizophrenic patients has some sexual issue, and also the people who receive antipsychotic, we will see that will still have some sexual issue because the level of prolactin is not controlled. So this is how the dopamine is involved in our brain, and how like the change in concentration or level of dopamine in our brain might lead to appearance of schizophrenic symptoms. Okay, so based on that picture here, how can we treat schizophrenia? Now, let's say that we have a patient patient who has positive symptoms. So if I tell you briefly that a patient has positive symptoms, what is the meaning of that regarding to dopamine in his or her brain? I need someone to answer me, please. If I tell you that someone has positive symptoms, what is the meaning of that regarding to dopamine in his brain?
Hallucination.
Okay, yes, exactly, hallucination. But why this happens? Because what happened to dopamine in his or her brain? Hello?
There is increase in the dopamine. There is increase in the dopamine.
Exactly, thank you. Increase in dopamine, we have to be specific in the Mesolimbic pathway, because if, for example, the increase in dopamine was in the mesocortical, it will not lead to the positive symptoms. Okay, so we need to be specific about it. We need that because we will see how medications treat schizophrenia, and we will see why second generation is now preferred over first generation. So positive symptoms, high dopamine in mesolimbic pathway. Okay, this is regarding the disease and how it happened. Then we need to talk about the dopamine receptors. So mainly in our brain, the receptors involved regarding to dopamine are D1, D2, D3, D4, and D5. 5 subtypes of dopamine receptor. However, D1 and D2 are the main ones. These are the ones mainly involved in the development of schizophrenia. And D2, this one is the target one, because it is the one where the antipsychotics, either the first generation or the second generation, work on. So our main focus now will be on D2 receptor. Here, the dopamine come to work. Any change of dopamine level leads to the change that we talk about, either positive symptoms, negative symptoms, change in prolactin level, change in movement. Like we said, if dopamine is high in nigrostriatal pathway, it will lead to tics and dyskinesia. So the target we need to focus on is D2 receptor. Okay, so here if we talk, I'm just giving you like a brief summary of the disease. We will go in details later, just to understand how the disease happened and how the medication work. If we start by the first generation, which are typical antipsychotic, which are the older version of antipsychotics, we will see that it works with less selectivity, like it works almost everywhere on D receptor everywhere in the brain. This is why it's mostly associated with many side effects. And this is why we don't depend on it anymore. Second generation are more common now. Clinicians nowadays don't prescribe first generation unless the patient has clear contraindication to second generation, or the patient is unresponsive at all to second generation. So regarding the first generation antipsychotics, we will see that. Let's start with the Mesolimbic pathway. We said that antipsychotic block D2 receptor. So when I block D2 receptor, it's like I decrease the dopamine level in the body or in the brain. I don't decrease it, but what happened? When I block the receptor, the dopamine cannot work anymore on the receptor. So if we start by the first one, which is the Mesolimbic pathway, we said that what happens in the disease is that the high level of dopamine on the Mesolimbic pathway leads to, hello?
Decrease.
No, the increase of
Positive
dopamine
symptoms?
in the, yes, exactly, positive symptoms. So when the first generation block the DT receptor in the mesolimbic pathway, what will happen to the positive symptoms?
It will decrease. That's all.
Exact. Okay. So this might be what you mean, but okay. So yes. So this is a positive result that I need to reach, like decrease of the positive symptoms. Correct? So, but how about other D receptors in the other pathway? Here in the mesocortical pathway, as we see here, when we said in the disease itself that the decrease of dopamine in the mesocortical pathway leads to the negative symptoms, correct? Hello?
Correct.
Yes.
Yeah.
Correct, yeah.
Yeah. So when the first generation antipsychotic like haloperidol, for example, work on the DT receptor on the mesocortical pathway, the red one here, what will happen to the patients?
In the mesocortical,
Yes.
what
Get
happens?
depression.
The negative signs will be decreased also.
The negative signs will be decreased or increased?
No,
Increased.
it will be no, it will be decreased because
No.
increase the dopamine in the
No.
mesocortical.
No, if you go up here, we said that the low dopamine in the mesocortical pathway leads to the negative symptoms, okay? Here decrease, this is the disease. So when I take first generation antipsychotic here, it decrease because it blocks the dopamine, it will decrease, like it decrease more the dopamine level in the brain, correct? Because I'm blocking the receptor.
Okay.
So the negative symptoms will increase more. And this is one of the drawbacks of the first generation antipsychotics. When the dopamine is less in the mesocortical pathway, the negative symptoms will be more. This is why first generation antipsychotic is not favorable due to that. Is it clear?
Yes, it's
Is
clear.
anyone confused about this point?
I'm a little bit confused still.
I'm sorry?
I'm still a bit confused about the positive signs and negative signs. Can you repeat it again?
Okay, let's go to the about the positive symptoms. I'm sorry, who said that he is confused? Can you clarify to me why are you confused?
Ahmed, my name is Ahmed. I'm a little bit confused regarding the mesocortical you have just mentioned.
Okay, what is the confusion exactly? Like
when the dopamine when
you see here, this is a disease itself. This is schizophrenia. Okay. So this is a brain, and now in the mesolimbic pathway, if dopamine increase, it will lead to positive symptoms. In the mesocortical pathway, it is the opposite. If dopamine decrease, it will lead to the negative symptoms. So when I take antipsychotic, it will block dopamine in the mesolimbic pathway, like it will decrease dopamine. So what will happen to the positive symptoms? It will be less, correct? Ahmed, are you still there?
Yes, I'm following.
Okay, so you are with me on this part, positive symptoms, correct?
Yep. So,
okay.
So in the mesolimbic, the saying that dopamine when dopamine increase, it will increase the mesolimbic side effect.
When dopamine increase in the mesolimbic pathway, it will increase the positive symptoms.
Increase positive symptoms. Okay.
So when I take antipsychotic here, it will block the dopamine receptor. So it will make like dopamine effect less, correct?
Yes.
So the positive symptoms will disappear.
Okay.
On the other hand, the reason for the appearance of negative symptoms is that dopamine is low in the mesocortical pathway, this area, okay? So the negative symptoms is associated with the low level of dopamine in the mesocortical pathway. So when I take antipsychotic and it blocks the D2 receptor in the mesocortical pathway, so dopamine will be less, correct?
Yes.
So the negative symptoms will be more. Are you following with me now?
Sorry for this.
No,
The-
doctor, you said it's less. In mesocortical, you said dopamine is less. Yeah?
Yeah,
When you take antipsychotic, it means decrease more the dopamine.
exactly. Which means more negative symptoms, like low mood and depression.
What was the benefit?
This is why we are talking about the first generation antipsychotic. It's not favorable anymore because it does that. Because although it improves the positive symptoms, it might increase the negative symptoms. This is why we don't use it anymore. I'm talking about the first generation now.
Dr. Ayman, just
Yeah.
to clarify. So dopamine when increase in the mesolimbic, it increase
Positive symptoms.
positive symptoms. While in the mesocortical, when you are mentioning when dopamine decrease,
Yes.
it will. This is, I mean, okay. In order to unify, what if happen if dopamine increase in the mesocortical? Increase.
If dopamine increase in mesocortical, so
Yes.
the negative symptoms will disappear.
Okay.
Okay, but
Okay.
this not what happened with the first generation antipsychotic because it blocks the D receptor in the mesocortical, so it makes the dopamine effect less, meaning that more negative
Negative
symptoms.
symptoms. Okay.
Okay,
I got it. Okay.
why I'm telling that in the beginning, because the question is why we are using the second generation, not the first generation. This is the answer. When I come to talk about the second generation, I will tell you something totally different. Okay?
Okay.
Okay. Is anyone confused about this part, mesolimbic and mesocortical? If you are not confused, say it's okay, I'm fine. Like, okay?
It's okay. It's okay. Thank you.
My
It's
pleasure.
sharp, clear.
Okay. Also, if the antipsychotic, the first generation, blocks the D receptor in the nigrostriatal pathway. We said that nigrostriatal pathway is like responsible for movement. And we said that low dopamine level will lead to dystonia, which is involuntary muscle contraction, and Parkinson-like symptoms. So if I take antipsychotic first generation and it blocks the D receptor in the nigrostriatal pathway, what will happen to the patient?
It will increase the nigrostriatal. Increase.
Yeah, it will increase the movement, like the involuntary movement, correct?
Yes.
This is what we call it extrapyramidal symptoms. This is how extrapyramidal symptoms appear due to taking first generation antipsychotic, because it blocks the D receptor in the nigrostriatal pathway, making the dopamine effect less in the nigrostriatal pathway, leading to extrapyramidal side effects. Okay? Okay, So we are talking now about the fourth pathway, the purple one here, which is through Infundibular Pathway. So we said before that dopamine here will decrease prolactin. Okay, so if I take antipsychotic that work on D receptor on this pathway, what will happen to the prolactin? You can even write, you don't have to say by voice. If I take increase, thank you, Noha. So yes, that's correct. So if I take antipsychotic that work on D receptor and it block D receptor here, it will lead to increase of prolactin, leading to a situation or a case called hyperprolactinemia. So it's a case of high prolactin in body, leading to gynecomastia, which is enlarged in breast size in males, leads to sexual dysfunction too. Okay, this is regarding the bad, the unfavorable first generation antipsychotic. You see, it makes a lot of unfavorable side effect. Okay, now we will talk briefly about them. So we have two main classes of these first generation antipsychotic, the high potency and low potency. Most of them are high potency, including the haloperidol, fluphenazine, prochlorperazine, and trifluoroperazine, high potency. So they bind firmly to the D receptor. So what will happen when it binds firmly to the D receptor? It means that the side effect associated with less dopamine will be high. Like, for example, here, if we talk about the nigrostriatal pathway, when it binds firmly to the D receptor there, it will lead to EPS, extrapyramidal symptoms. We see the hand here. I'm sorry. Yeah, we see the hand here like extrapyramidal symptoms. Also, when the dopamine, when they bind firmly to the D receptor here, we will see that the prolactin is very high, leading to gynecomastia, sexual dysfunction. However, the low potency one is the chlorpromazine, and it's not commonly used now. So this one binds less firmly to the D receptor, which means that the side effect associated with dopamine is less. However, this chlorpromazine binds to other receptors, like what? Like alpha adrenergic receptor, like cholinergic receptor, and H receptor, histamine receptor. So I'd like to ask, may I select from the participants? I will ask Ahmed Tantawi, what will happen if a medication binds to cholinergic receptor? What are the side effects developing here?
I think it will cholinergic. It will having the dry mouth and blurred vision.
Yeah.
And I think urinary retention.
Yes, exactly. You see, dry mouth here. It's like fluid retention, and here like the blurry vision. Exactly. Okay, what will happen if a medication binds to H receptor, histamine receptor? I will ask Mina Ayat to answer this question, please. Mina, are you there?
Hi.
Hello.
Yes.
So what
Can you repeat
happened?
the question?
Yeah, what happened if a medication block histamine receptor? What are the side effects developing?
Like block the histamine receptor?
Yes. What happens when you take antihistaminic like Benadryl, chlorpheniramine maleate, or chlorpheniramine maleate, or diphenhydramine? What are the side effects?
The side effect from them, like so usually we give the antihistamine that someone has like runny nose, or so they will stop the runny nose, they stop the itchiness, they stop the hives.
Yeah, this is a good benefit, but how about the bad result, like the side effect of antihistaminic?
Dizziness,
Yeah,
drowsiness.
sedation. You see the man here is sleeping on the desk, sleepiness.
Yeah.
And also it will increase weight.
True.
Yes, so these are the side effects of chlorpromazine because it blocks the histamine receptor. Okay?
Mm-hmm.
Yeah, thank you so much. Also, chlorpromazine block adrenergic receptor, leading to hypotension. So, based on the things we are talking about the first generation here, why would a doctor prescribe them anymore? There is no point. A lot of side effects. At the same time, the action of this medication on the disease itself is less because it contributes to more negative symptoms. So no need anymore to prescribe the first generation antipsychotic. Is it clear for everyone now why we are not using the first generation antipsychotics? Anyone have a question until now? No question. Means everything is clear, or hopefully everything is clear. Okay.
Yes, sir. Thank you.
Thank you. Let's talk about the good family, the second generation. To be honest, there is no perfect thing in life, but at least it's much better than the first generation. Okay, I need someone who is fully focused because I have a question. It's a general question about the disease now, to ask him a question or her about the second generation before I start talking about them. Would anyone like to volunteer to ask him or her first? Anyone would like to volunteer?
Yes, sir. Yes, ask me. I am Armia.
Hi, Armia. Okay.
Hi, sir.
So I like to ask you a question. Based on what we said about the first generation, what would you like to have in the second generation? Like what is the bad thing about first generation in addition to the side effect? What else you would like to see in the second generation to say, oh, okay, these are good medications to use for schizophrenia?
Okay, so to be less of the side effect, the more significant side effect here is the EPS. So the second generation in less in the EPS.
Wonderful. What else?
Okay, and also, okay, and after the EPS, about and the less in decrease in the prolactin.
Okay, we are still about the side effect now, but
Yes,
I need you to tell me about the efficacy more. What would you like to expect from a good medication?
Okay, we expect more more significant improvement in the positive signs. There is no delusion, there is no hallucination. Okay.
Yeah.
And for the negative signs, from my study, it is still there. The second generation cannot affect the negative sign anymore, even it is the second generation. Okay,
so I would respond to this point because this is what I'm looking for. I see Rini here.
I am right, sir. I am right.
To some extent, there is no right or wrong. Like we will discuss it, but what I need to see here, like what Irini said. I'm sorry. There is a voice from someone there. What I like to see in a good medication to treat schizophrenia is to work more against the negative symptoms, like what Irini said. Okay, so let's see how will this happen through the second generation. Okay, Okay, so here I have the second generation antipsychotics. So they will work on the DT receptor like the first generation, which means there is a chance to develop the side effect like the first generation. However, the second generation have a very good characteristic, which is blocking the 5-HT2A receptor, which this is a subtype of serotonin receptor. So what happens when we block this receptor? Blocking serotonin receptor 2A leads to the increase of dopamine receptor in the area where we would like dopamine to be high, which is the mesocortical pathway. Again, a medication like Olanzapine, for example, it will block D2 receptor in the mesolimbic, leading to improvement of positive symptoms. At the same time, when it blocks the 5-HT2A receptor, this will lead to less serotonin and high dopamine in mesocortical pathway, leading to better control of negative symptoms. It's not a full control, so it's like a better control. Is this point clear now why the second generation is more preferred now and how this happened? Hello?
Okay. Can I speak? Can I tell something, sir, please?
Yes, you can.
Okay, when I read a wonderful sentence said that the second generation antipsychotic not worsen the negative function in the psychotic patient, not worsen it, maybe not improve it, but in the other hand, not worsen it.
So
unlike the first generation.
Yeah, what did I say? I say that better control, no full control. So to make this sentence more precise, it improves the negative symptoms to some extent, but not fully.
Yes.
Okay? This is why the schizophrenic patients never reach to a fully normal status. He or she still suffer from something, but it's under control. And this is what we are looking for. And this what distinguish second generation antipsychotic from first generation. The blockade of the 5-HT2A receptor in the brain lead to this serotonin receptor, lead to increase in dopamine in other area like the mesocortical, giving more control, more improvement for the negative symptoms. And this is the big point I'm looking for in treating schizophrenia, to control positive symptoms by blocking the DT receptor, mainly in the Mesolimbic pathway, and at the same time, increasing dopamine level at the mesocortical pathway, leading to partial control, to be precise, of negative symptoms too. Is it now clear why we like the second generation more than the first generation?
Yes.
Okay. Okay. Those are our second generation antipsychotic. And they are associated with many side effects that are confusing to us. But if we know how these side effects develop, it will be easier for us to remember the side effect associated with each one. So let's start with the pine family, Olanzapine and the Clozapine. These two medications are mainly associated with high glucose levels and high lipid, and also increase in weight. Why this happen? Because they block the 5-HT2C. Now, in addition to here, in order not to be confused, in addition to blocking the 5-HT2A, Olanzapine and the Clozapine block the other one, the other subtype of serotonin receptor, which is 5-HT2C receptor, and blocking this receptor increase the appetite, leading to high weight gain, leading to high glucose level, leading to high lipid level. Now we know why Clozapine and Olanzapine do that due to working on that receptor. Okay? Okay. Second one, Olanzapine, Quetiapine, and Clozapine. In addition to the fact that Olanzapine and Clozapine block 5-HT2C receptor, they also block the H1 receptor. And we said, if a medication blocks the histamine 1 receptor, what will happen? Dizziness, sleeping, weight gain. So the weight gain here with these Clozapine and Olanzapine result from two facts. The first one is increased appetite due to blocking 5-H2TC and also blocking H1. For Quetiapine, the increase in weight results from only working on H1, which means that the weight gain with Clozapine and Olanzapine is still higher than Quetiapine because there are two factors here for Clozapine and Olanzapine, while it's only one factor for Quetiapine. Is it clear until now?
Yes, sir.
Okay. The third one is Respiradon and Clozapine. Both still block alpha-1 receptor, leading to what? Low blood pressure. And when your blood pressure is low, what happens to your heart? Tachycardia, trying to increase the blood pressure. So you might think, oh, okay, these are the same receptors that were blocked by the first generation. So we should expect the same side effect. The answer here is no, due to a simple fact. The binding power or the binding affinity of the second generation antipsychotic to these receptors, alpha-1, H1, other receptors generally is less than first generation, which means less side effect. So the side effects are still there, but less, clearly less compared to the first generation antipsychotic. Okay? Okay. Risperidone. And the active form of Respiradon is Palpyridone. There is something unique about this medication, which is these medications are highly associated with extrapyramidal side effect. These are the only two second generation antipsychotic associated with extrapyramidal symptoms. Can anyone tell me why from what we said before?
The Respiradon and what, sir?
And the Palpyridone, which is the active form of Respiradon. Are you still Armia?
Yes, sir. Can I answer if you want?
I need someone else to participate with us. If you allow me to do that, please. I mean, I need our other friends to share with us. Anyone would like to participate, telling me why Respiradone and Palpyridone are associated with extrapyramidal side effects?
Maybe because of it have an active form, so it's like making high affinity. So that's why it's increase the side effect of extrapyramidal side effect.
Okay, the question is still there, but why? Why extrapyramidal side effect? Because it binds to D receptor where exactly in the brain?
In the mesocortical?
No, we said which part of the brain is associated with the EPS?
Nucleus striatum.
Thank you, Noha. Thank you, Samar. Yes, exactly. So because Respiradone and the Palpyridone bind firmly to D receptor in the nigrostriatal pathway, leading to extrapyramidal side effects. Also, the same two, Respiradon and the Palpyridone, are associated with hyperprolactinemia. The reason is, I will ask someone directly now. I will ask Samar Kassab. Are you there? Okay, Samar is not there. Rahaf, are you there?
Hello, doctor. I missed the first few times of the class. That's why I can't answer right now.
Oh, okay, no worries. Thank you. Anyone would like, my pleasure. Anyone would like to answer me why Respiradon and Palpyridone are associated with hyperprolactinemia?
Because
yes,
they attach to the
Infundibular, yes. Thank you, Irini. You are silent, but you share with us. Thank you so much. Yes, exactly. Because they bind to the D receptor in this difficult pathway, Infundibular pathway, leading to high prolactin, which is a case of hyperprolactinemia. The symptoms associated with hyperprolactinemia are gynecomastia, sexual dysfunction mainly. Okay, so this is the disease and these are the medication briefly. Now we understand why the disease happened, how we select the medication, why this medication is better than that, and also why the second generation is better than the first generation, and why the side effects appear the reason for that, so we don't forget it. Now we will share the main file now.
Dr. Ayman.
Yes.
One thing regarding the alpha-1, that
yes,
Clozapine and Respiradon, they both have an effect on the alpha-1 selectivity, so they have a hypotension effect. Am I right?
Yes, because they block alpha-1.
Okay.
Yeah, I still have a more detailed file about that. We will share it right now. 1 second.
Also, you have written above here on this chart that agranulocytosis.
Yeah, I will talk about each medication separately. I was giving like a bigger image of the thing, but we will talk about everything now in details.
Dr. Ayman, please correct me if I am wrong. The Olanzapine, I read that on the monograph. The Olanzapine, it is also have alpha-1 adrenergic blocker.
To some extent, yes. But
yes,
it's
because they causes some side effect from the alpha-1 adrenergic blocker. That is because when I see your draw, you are connect the Clozapine with the alpha-1, but also the Olanzapine have alpha-1 adrenergic blocker.
because the Clozapine effect on alpha-1 is much higher. When I put it like that, it doesn't mean that others don't do that. They do, but to a less extent. Every medication can bind to many, many receptors. So we cannot discuss everyone in detail. We focus on the main side effect and associated with which kind of receptor. Okay?
Thank you.
But this doesn't mean that it doesn't connect to other. It might connect, but what is the side effect? Is it something that I have to be worried about? No. Okay?
Okay, sir. Thank you.
My pleasure. So now, let's see again what we said, but in a detailed way. This is like a definition of psychosis, complete detachment from reality, as patient won't be aware of his action during the attack episode. Like psychosis, sometimes this is the definition that some public people define it as craziness. When you describe someone as crazy, because he is detached from reality. Unrealistic thoughts, unrealistic behavior. But the important point about psychosis is that it's not usually there. It's like episode that affects a person, maybe for a few days, a few weeks, depending on the severity of the case, but it's not usually there. This is why some people might be admitted to the psychiatry hospital for a few weeks. Why? Because they have the episode of psychosis, but far from this episode, they are controlled by medication. and we talk about the positive and the negative symptoms and the difference between them.
يا ماما انا قاعد تحت وحسين سايبه فوق، انا قلت انت قلت لي جايه على طول وقدامك نص ساعه والحاجه سايبها في الفرن.
يا حسين. I'm sorry, the dad of Hussein, we are hearing you. If you can unmute your microphone, please. Thank you. So we talk here about the symptoms. We have positive symptoms, negative symptoms. Okay, and we discussed that already. And also it's associated with some cognitive and mood symptoms. We said that the patient is depressed, low mood, less socialized, would like to be alone. We already go through that, okay? Reduced drive and motivation, lack of energy, depressed mood, that's so common. Okay, now, is the non-pharmacological way considered a basic or a main way of treatment in psychosis or no? I'm not sure which topics you already talk on psychiatry. We will find that some of them can be treated by non-pharmacological or cognitive behavioral therapy, and it has a big role, others not. So I need to ask you, for psychosis, do you think that non-pharmacological have a big role in treating the disease or not? Like cognitive behavioral therapy or whatever? I'm asking, I need an answer.
Okay, no, sir.
Thank
No.
you. Yes, so the answer is no. The non-pharmacological, just a complementary. It's about communication with the family, clarifying the disease for them so they understand the behavior of the patient more. But it doesn't have a direct role in dealing with schizophrenia itself. Okay, so, and we said about the kind of receptors here, we already clarified that. We talk about the first generation and second generation and why it's associated with these weight gain, sedation, and this stuff, that's fine. The point we need to mention here is that the antipsychotic are associated with something called neuroleptic malignant syndrome. And we will talk in details about that because the neuroleptic malignant syndrome can come in the MCQ or in OSCE as well. Okay, so these are the details we are looking for about each medication. Now, we talked already about Clozapine before. It has high affinity to D1, D4, 5-HT2, two types, 2B with 2C, M receptor, alpha receptor, and it has a weak dopamine receptor antagonist. So as we see here, it works on many receptors, but which one we really care about are the one mentioned here. Clozapine, alpha-1 and the associated low blood pressure, and also 5-HT2C associated with high glucose and the high lipid level. We don't have to take all information. We need to focus on the main thing that we need. Hello, Ayman. I already clicked that Shams. Okay. Also, Respiradon. We said about Respiradon and its active form, Palpyridone, that it increases the extrapyramidal side effect and it's associated with hyperprolactinemia. This is what we need about Respiradon. Aripiprazole is one of the nice, to some extent, I would say, nice medication. It has a partial agonist effect on DT receptor and the 5-HT1A receptor, and antagonistic at 5-HT2A receptor. The side effect associated with aripiprazole is less compared to others. Quetiapine. This quetiapine has many uses. If you take the bipolar, you will find that it can be used. If you take the depression, you find that it can be an added therapy for depression. And now it can be used for schizophrenia. So why this happens with quetiapine? Why quetiapine is unique in this family? because it acts on many receptors. It blocks the DT receptor more potently than 5-HT2A receptor, which means that it will be a potent antipsychotic. Okay. Also, the quetiapine, if I found, for example, a patient taking Respiradon and develop extrapyramidal side effects due to blocking DT receptor in the nigrostriatal pathway, what's my alternative? It's quetiapine. It is the least one associated with EPS. Clozapine is also less associated with EPS, but clozapine is different medication. We will talk about it separately. This is why we don't use it. We tend to use quetiapine more. Okay. Okay, now a patient is diagnosed with psychosis and I need to start treatment for him or her. How would I do that? First of all, some psychiatric disease can be treated by multiple medication, like depression, for example. I can give the patient 2 or 3 medication together of different families. Bipolar is the same, can be treated by 2 or 3 medications. I need to ask you, schizophrenia, is it mainly treated by one more medication? I need an answer, please. And why?
Medication from the antipsychotics or different medication?
Generally speaking, do we treat psychosis with one medication or combination of medications? Muhammad Wali is saying one to avoid many side effects. Okay. Yes. Okay. Anyone has another answer to contribute? I'm sorry, people, I see that 3 or 4 people are only participating with us. I would appreciate if everyone contribute, even if it's a wrong answer, don't worry. We are starting to discuss the topic. It's okay that you don't know everything about the topic, but please participate with us. I believe one medication. Thank you, Niveen. Anyone else would like to say something or not? Please.
It is one medication for the psychosis, but there is other medication for some side effect.
Okay. My question is about psychosis itself. So the answer is yes. Yeah.
It's one medication.
One medication. And the answer is why, briefly, because they all have the same mechanism. We didn't talk about different mechanism of action. It's all about blocking D receptor. So there is no alternative. It's only one medication, nothing else. When we talk about antidepressants, we say that some of them are SSRI. This is a mechanism. One of them is adrenaline and serotonin reuptake inhibitor. This is a different mechanism. But for this one, it's only one mechanism, blocking D2 receptors. So there is no point of using, for example, Olanzapine and Respiradon. Why? They are doing the same mechanism of action. So no point of using more than one medication. So yes, you are all correct. Okay, so now, if it's the first episode, the first time to have schizophrenia, what I do, I use, for example, Olanzapine. Let's start with Olanzapine for 2 weeks. Okay, I start with low dose, 2.5 milligram. Then after 2 weeks, I increase the dose depending on the tolerability of the patient to the medication. Okay, when would I decide that this medication failed? Okay, I need to change Olanzapine now. After 4 to 8 weeks. Mainly the doctor gave it 8 weeks, like 2 months, to judge or to decide that, okay, Olanzapine is not working anymore, so I will change the patient to a different one. A different one means the same family, but a different member. It was Olanzapine, okay, let's go now for Respiradon. Let's go now for quetiapine. But the question is, If I am changing a patient from Olanzapine to Quetiapine, for example, do I stop it today and start the other one tomorrow? No, I need to make a crossover between the two medication, which takes 2 weeks to 3 months, depending on for how long I use the first medication. For example, I give Olanzapine to Mr. X for 2 months and there is no response. And I need to change him to Quetiapine. So in that case, I will start to gradually decrease Olanzapine while starting and increasing Quetiapine. I'm sorry, we said that he was on Olanzapine, so we will start to gradually decrease Olanzapine and giving you Quetiapine and increasing it. If the patient has used the Olanzapine for only 8 weeks, I can make the crossover in only 2 weeks. But if the patient has been on the medication for 1 or 2 years, I might need up to 3 months to make this crossover. So this period of time depends on for how long the patient has been using the main medication. Okay? The third question is, for how long I use the medication? So if it is the first episode and there is no suicidal thoughts, and this is important factor in deciding, the patient has the first episode of schizophrenia with no suicidal thoughts, so it will be around 2 years, but it might increase. But if there was suicidal thoughts, it might be up to 5 years. Okay? Okay. Now, I have given Mr. X drug X of antipsychotics, and he was stable on it. And I need to stop it now. How can I stop the antipsychotic medication? It needs up to 1 year, from 6 to 12 months to stop this medication. It's not like SSRI or other medication. It takes a lot of time. Otherwise, the patient will relapse. Okay, what if it is the second episode? The same way, I will titrate, like I will give him the medication, like for 2 weeks, titrating up. Then I will decide if it's working or not after 4 to 8 weeks. And if it's not working and I'm changing him to a different medication, it will be between 2 weeks to 3 months, but the length of the therapy for the second episode is 5 years. Okay, if the patient has achieved improvement after the second episode, and I need to stop the antipsychotic medication for him, how can I gradually withdraw the medication? It takes up to 2 years. 2 years in addition to the 5 years of treatment to stop the medication. And if I make it faster than that, the patient will relapse again. Okay. Regardless of what is written here, can anyone tell me what actually happens in real life about the length or duration of therapy for schizophrenia, regardless of 2 years and 5 years? What actually happens in real life for schizophrenic patients? Lifelong. Thank you, Mohammed. That's it. I have never seen a patient on antipsychotic and stopped it. And what happens in actual life is that in a trial of stopping the antipsychotic medication, a relapse happens and the patient goes into a second episode and a third episode. So mostly a patient on antipsychotic will stay on it lifelong. But this is what we need for the exam, the numbers here, but the actual life, no. Antipsychotic are lifelong. Okay, regarding titration, we were saying here that we will start and titrate in 2 weeks. Do we have to titrate all medication? The answer is no. 2 medication don't need titration, asinapine and lorazepam. And other 2 can be rapidly titrated. Ziprasidone, and the quetiapine XR. And keep in mind, it is the XR formula, not the regular quetiapine. Regular quetiapine needs regular titration, but the XR, the extended release one, can be rapidly titrated. Okay, these are the side effects we talk about, and we already illustrated why this is happening. I'm not going to repeat it, but I will select random ones to tell me why this happened with that. Okay? Okay. So, Clozapine, Olanzapine, and the quetiapine cause sedation. Why this happened, Suzanne Shreem?
They work on histamine receptors.
Thank you so much. So, Respiradon and its active form Palpyridone cause EPS. Why this happened with that? Wafa, are you there? Okay, Shaima, are you there?
Yeah, I am here.
Okay, why Respiradon and Palpyridone cause extrapyramidal side effects? If you don't know, that's fine. You were with us from the beginning of the lecture or not?
No, because it's a block dopamine.
What, sorry?
It's a block dopamine.
Yeah, block dopamine where? Because it depends on which pathway it block dopamine at.
And the mesolimbic?
No, the mesolimbic is associated with positive symptoms. So, yeah, nigrostriatal, blocking dopamine in the nigrostriatal pathway. Yeah, okay? Okay. So, Irini, I see that you are active, so I'm going to ask you why Palpyridone, Clozapine, Olanzapine, and the quetiapine are associated with weight gain. Irini, are you there?
Yes, act on antihistamine, histamine receptor.
What else?
Because it blocks the serotonin. Sorry.
Yeah, and also, so quetiapine block histamine receptor, but olanzapine and the clozapine also block the histamine receptor. You remember that from the graph here? Let's see it together again. Olanzapine and the clozapine block the 5-HT2C receptor, leading to increased appetite and increased glucose and lipids. And also, in addition to quetiapine, they block the H1 receptor, leading to increase in weight. Okay? Yes, plus 5H2TC. Thank you, Mohammed. What else? Yeah, metabolic abnormality. Metabolic abnormality means like high glucose level, high lipid level, these things. And we said that it's associated with clozapine, olanzapine, and the quetiapine to their effect on the 5-HT2C receptor, leading to high appetite, leading to more desire in sugary food. This is why metabolic abnormality happen with these three medication. Hyperprolactinemia. So Respiradon and its active form Palpyridone. Leah Counsley, are you there? Leah? Okay, Latifa. Oh.
Yeah.
Yeah, okay, sorry. You are Latifa or Leah? I'm sorry.
I said hi.
Hello, sorry. Okay, so why Respiradon and Palpyridone are associated with hyperprolactinemia? Leah, are you there? Latifa, are you there? You can write. Yes. Okay, Mohammed, I will take your answer. I'm not sure what happened to Leah and Latifa, but yes, because they work on the temporal infundibular pathway, it means that high prolactin leading to hyperprolactinemia. Log DT and yes, Irini, thank you. Cardiovascular effects, Respiradon, Clozapine, Quetiapine. What these people, these medication, Clozapine and Quetiapine, do to affect the cardiovascular system? Alpha-2 blockade. Thank you, sir. However, Respiradon affects the cardiovascular system in a different way because it causes QT prolongation. So this is how it affects the cardiovascular system, Respiradon. Okay, we will talk about it separately too, but this is how it doesn't work on alpha-1 like the others. It increases the QT, it causes QT prolongation, to be more precise. Okay, now we have injections, and one of them is Respiradon, one is Palpyridone, and one is aripiprazole. I need to ask you first, we have never seen injection for antidepressant, for example, but why we are seeing injection for antipsychotic? Anyone has a rationale for that? Why we are making injection for antipsychotics? I need your contribution.
Yeah, I think because in case of psychosis, there is agitation. That's why we want the patient to be calm easily, not like antidepressant. It's like acute case, especially in psychosis, it's acute case, but depression, sometimes it's like a chronic.
Okay, this is a good rationale, generally speaking, for injections, like the fast effects, but it's somehow different in schizophrenia. You know why? Because the injection takes time to work in case of schizophrenia. For example, if a patient has been taking Respiradon tablet for some time, and I'd like to give him Respiradon injection, you know how we do that? We keep him on the tablet and we give him the injection, and we can stop the tablet after 2 to 3 weeks. The injection in case of schizophrenia takes time. So your rationale is right, but in general disease, not in schizophrenia. You know what I mean?
Can you repeat again, please?
Okay, so our friend here said that injection is okay to control agitation because psychosis is associated with agitation. So we need to get like a fast effect. This is why we give injection. Okay. However, the fast effect is not the goal here in psychosis, because the injection here are long acting. It takes time to work. But there is a different reason, totally different reason. Don't think about it scientifically. Think about it socially or about behavior. Why I'm giving schizophrenic patient injection?
For the long-lasting effect.
Yeah, Irini, I'm asking because I need you to, like talk to me, share with me your thoughts. You know, this is how we can keep that. Okay, yeah, this is, yes, this is what I'm looking for. Yes, adherence, compliance, yeah, that's it. Schizophrenic patient, think about it. Like, for example, a patient has an episode. Will he take the medication? Mostly no. Those people are very agitated, unresponsive to anything. They might close the door of their room and don't talk to anyone. And they might throw away their medication. At that point, what can I do? The episode will be worse. This is why some doctors prefer to give the injection. He will take it One of them is every 1 month, other is every 3 months, and forget about it. Now, is it clear why we give injection in case of schizophrenia? Because we cannot trust the patient. We cannot, like what you said exactly, the patient might not be adherent. Okay? Okay. Now, if we talk in details somehow about the injection, the first one is Respiradon injection. Its brand in Canada is called Respiradon. We give it every 2 weeks. Okay? Aripiprazole, we give it every 1 month. I left Palpyridone to the end because it has a specific regimen and we have 2 products of Palpyridone injection. So Palpyridone, how we start the injection? We give the first injection today, the second injection after 1 week, the third injection after 1 month, and then we take it monthly. Okay. 1 injection today, a second injection in 1 week, a third injection in 1 month, then monthly. Okay, what I would like to tell you about Palpyridone injection, its brand in Canada is called Enviga. And this brand has 2 subtypes. One is called Enviga Sustenna, and the other one is called Enviga Trenza. Anyone can help me or tell me what is the difference between these 2 injections? And when I use that, when I use this might be out of scope as an exam, but in the OSCE you might need it, in your practice you might need it. So let's cover it now, so you remember it. Anyone knows the difference or can contribute his or her thoughts about Enviga Sustenna and the Enviga Trenza? No thoughts? Okay, you are with me. Just, okay, I'm not talking to myself, correct? Just to make sure that the voice is not disconnected. Anyone
Yes,
say?
sir. Yes,
okay.
We hear you.
Okay, so Enviga Sustenna, it comes in the strength of, oh, okay, Ziad, with you, but no idea. Okay, Nohan, thank you. So my question was, what is the difference between Enviga Sustenna and the Enviga Trenza? So the answer is, Enviga Sustenna comes in the strength of 156 milligram per ml. However, Enviga Trenza come in the strength of 312 milligram per ml. So it's double the strength. So this is why the Sustenna, which is the low strength, is every month, but the Trenza is every 3 months for more compliance. Okay, but Trenza is every 3 months, not only because of the high strength, but also because of the formulation of the medication itself. The particle size of the Trenza is bigger, means it takes more time to distribute to body. This is why it takes longer time. So the question now is, regarding this, Palpyridone injection, start today, after 1 week, after 1 month, then every month. Which one we are talking about now? Enviga Sustenna or Enviga Trenza?
Sustenna.
Yes, thank you. The second question is, if I would like to convert a patient from Enviga Sustenna to Enviga Trenza, what is the criteria to change the patient from this to that? The patient need to achieve stability on the Sustenna for 4 months. If I have been giving the patient the Sustenna every month for 4 months and the patient is stable, at that point, I can convert him to Enviga Trenza. Okay, this is somehow out of the scope of the exam, but you need it in OSCE, you need it in your practice. Okay, any question regarding the injection part? So far, so good. No question. Okay. Okay, now asinapine. To be honest with you, asinapine is not the kind of medication you will find that you dispense it in the pharmacy every day. No, it's more common to give Olanzapine, to give aripiprazole, to give Respiradon, but not asinapine. Okay, what distinguishes asinapine? It's sublingual tablet. And this tablet should be taken in a specific way. You put it under your tongue and don't eat or drink for 15 minutes. 15 minutes before taking the medication and 15 minutes after taking the medication. So, for example, if in a case is telling you that Mr. Y has been taking asinapine since 1.5 months and he shows no response to the medication, what will be the first idea that come to your mind? Changing the medication, seeing how the patient is adherent to taking the medication, or discussing the way the patient is taking the medication. Okay, adherence is mostly about the timing of taking the medication. I'm adhering to a medication, it means I take it on time every day without interruption. So Mr. Y might be taking the asinapine every day after breakfast, which is wrong. He has to wait for 15 minutes. So it's, yes, administration. That's it exactly, Latifa. So you are here. I was calling you before like 10 minutes. So that's right. It's about the administration. Thank you. Also, never touch the asinapine tablet with wet hand. These tablets are like fast dissolving tablets. If your hand is wet, it will dissolve in your hand. No benefit. Okay? Also, take it right away. Open the blister, put it under your tongue, and that's it. Asinapine might cause tingling sensation in your mouth. And honestly, one of the common side effects associated with asinapine is bad taste. Usually the patient will tell you that I feel something like it tastes very bad, especially because it dissolved in his mouth under the tongue. So it tastes bad, honestly, and giving this tingling sensation. It can cause anaphylaxis or rash in the whole body, but this is like uncommon. It might happen, but it's rare to happen, but it's there. And also it might cause angioedema. I'd like to ask you something out of topic. What is the antihypertensive medication that is associated with angioedema?
ACE inhibitors.
Okay, and what happens if a patient develops angioedema on ACE inhibitor? What will you do?
Go to ARP.
Thank you, sir. What is the other class of medication of antihypertensive that might cause ankle edema in your ankle?
Amlodipine.
Thank you, Noah. Yes, thank you. That's it. And what happens? Okay. Noah wrote it. I'm sorry, Army. I know that you are sharing with me. Noah wrote it. Thank you. And what happens if a patient develops ankle edema due to amlodipine? What will you do?
We decrease the dose.
Exactly. You will assess the response to the amlodipine. Thank you, Noha, again. And thank you, Armia. Yes, you decrease the dose. But if the patient, for example, is not fully controlled under amlodipine, you will change him to something else. Okay? I'm sorry, this is out of the topic, but as a reminder, if we can connect topics together. Okay, this medication is new to Canada, like before 3 years, I believe. And yeah, so this one is a Piprazole. The good point about it, you remember, Armia, what we were talking about negative symptoms? We said that yes. Other second generation antipsychotic give like partial control over negative symptoms. This new one give like a good control, let's say, on negative symptoms. The unknown is unclear yet. The mechanism is not fully clear, but this is what they found by clinical trial, that it improves the negative symptoms more than other second generation antipsychotics. Also, it's associated with low extrapyramidal side effect which means it's more selective. So I will ask again the person, and I'm sorry to do that, whom I asked about the extrapyramidal symptoms associated with Respiradon and Palpyridone. It was Summer. Okay, I asked someone why Palpyridone and Respiradon is associated with extrapyramidal side effect. Whom did I ask this question, please? I need you to confess, don't hide from me. Who are you? Whom did I ask? I think it was Summer. Summer, are you there?
Yes.
Okay. Do you know why this new medication will be associated with less extrapyramidal side effects?
No idea.
What do you think? Okay. What was the reason for some medication to cause extrapyramidal side effects?
Because they decrease the dopamine in negro area.
Exactly. So this medication, the piprazole, like it doesn't bind to the D receptor in the nigrostriatal pathway. This is why it doesn't cause the EPS. Okay?
Okay, thank you.
My pleasure. So everything is associated. If we know the reason, it will be easier for us to figure out why. The same low weight gain, which means it doesn't bind to the histamine receptor and it doesn't bind to the serotonin receptor like Clozapine, Olanzapine, and the Quetiapine, and the same low metabolic complications. Okay, Zoclopentixol. This is a first generation antipsychotic, and sometimes, but they usually do that in the hospital, not in like in retail pharmacy. They might give this injection every 2 to 3 days, but it's not commonly used anymore. Okay, the distinguishing point about this medication is that you cannot give it to antipsychotic naive patients. Like if Mr. Z is recently diagnosed with schizophrenia, okay, and he doesn't try anything, the doctor would like to give him a medication. Which one the doctor cannot give him is this one, the Zoclopentixol, okay? This word naive remind us with what? The word naive remind you with what?
With the opioid?
Yeah, fentanyl patch, okay? We cannot use fentanyl patch in opioid naive patients. Okay, this is the bad guy of the antipsychotic, Clozapine. Let's agree on something. If I try Olanzapine to a patient and there was no response, what is the second step? To change him to something else, Quetiapine. What if he doesn't respond to Quetiapine? I change him to a third thing, like Palpyridone, for example. But what if no response? I have to use Clozapine at that point. So Clozapine is the last choice. However, Clozapine has superior efficacy compared to other antipsychotics. Keep that in mind. Clozapine is the most effective one, but it is the most dangerous one. This is why we don't go to it. Because it's associated with a granulocytosis, meaning low immunity, meaning more infection, and more severe infection that might lead to death. This is why Clozapine is avoided. Also, Clozapine might cause hypersalivation. Hypersalivation, like more saliva from your mouth. Also, it might cause urinary incontinence and also cardiotoxicity. So, Clozapine, what is unique about it? If you have a patient at your pharmacy who is taking a Clozapine, you cannot dispense the medication without the blood test. Again, If you have a patient at your pharmacy who takes Clozapine, you cannot dispense the medication without a blood test. And every time the patient is coming to refill Clozapine, he has to make the blood test before, and you make sure that there is no chance for a granulocytosis. This is when you can give Clozapine. Okay, how about Olanzapine? We already discussed the side effect of Olanzapine, but to remember, in addition to what we mentioned here in this graph here, like increase in weight, glucose and lipids, and also sedation, it decreased the liver function, okay? And it's associated with something called the DRESS. It's a kind of severe skin rash. And if it happens, if the patient is on Olanzapine and he comes or call you saying that I have like a weird rash appearing on my body, the response is go to ER right now or call 911. This DRESS reaction, the patient has to go to the emergency. It is characterized by weird rash, abnormal rash appearing on the body. Okay? Okay. The last thing here is the neuroleptic malignant syndrome, NMS. It's one of the side effects associated with antipsychotics. If it happens, you have to go to the emergency room right away, right away. What neuroleptic malignant syndrome? So it's associated with the patient might tell you, like, I have fever. This is very common. I have fever or hyperthermia. Also, the patient will tell you that I have palpitation in my heart, and this is mainly due to hypotension. And the patient will have like muscle rigidity, a problem in walking or moving his arm. This is like a reflection of neuroleptic malignant syndrome. Okay, so how they deal with the neuroleptic malignant syndrome at the hospital? First thing they give is dantrolene. Can anyone tell me why we give dantrolene, then bromocriptine to a patient? This side effect happens when you are taking antipsychotic. And we treat it by giving dantrolene, then bromocriptine. Dantrolene injection, then bromocriptine. Why? Muscle relaxant. Wonderful. So thank you, Irini, so much. So this is regarding dantrolene. Dantrolene is a potent muscle relaxant injection. The patient is coming to the hospital with severe muscle rigidity. I need to relax his muscle. So I give him dantrolene. The second question is why I give the patient bromocriptine. What is bromocriptine and what will it do?
Sir, bromocriptine is anti-dopamine, so it is decrease the dopamine.
No.
And increase the prolactin.
Think about it again. No.
Increase dopamine.
Thank you, Leah. It's a dopamine agonist, Armia.
Oh,
so,
sorry, I am okay. Yeah.
Yeah, it might be confusing, but that's fine. I'm giving the patient already antipsychotic, which is anti-dopaminergic. It's blocking the dopamine receptor, and this leads to the neuroleptic malignant syndrome. So I need something not to block the D receptor, to work as an agonist for the D receptor. This is why I give bromocriptine. I'm sorry, Noha, what do you mean for Parkinson? I didn't get it. If you can share with voice with us, just to make it clear.
I mean, we use it for Parkinson because it's increase the dopamine. That's what I mean.
Oh, okay. So, yeah, okay, I got what you said. Okay, thank you. So I cannot say that the muscle rigidity is Parkinson. I can call it maybe Parkinson-like symptoms because it's temporary. Parkinson is a disease, is a case, is a state of Parkinson. So yes, we use the dantrolene to overcome the Parkinson-like symptoms, which is muscle rigidity. Okay, but just to be more precise about it, not to use the word Parkinson, but maybe Parkinson-like symptoms or muscle rigidity. Exactly. So now we figure out how the NMS happen and why we use both dantrolene and bromocriptine. Then I have to tell the patient to avoid sun exposure. Why? And to keep hydrated. Why I have to tell him that?
Because in the NMS there is diaphoresis, and that is because we have to hydrate the patient.
Yeah, so hyperthermia, yes, means that loss of water from the body. So dehydration might happen. This is why is dehydration. Yeah, thank you. Yes, Noha, for hyperthermia. So yes, I need to overcome hyperthermia. So no more sun exposure and take more water to avoid dehydration. Okay, extrapyramidal symptoms. They were mostly associated with what? Respiradon and Palpyridone. Due to what? Due to working on the receptor on the nigrostriatal pathway. So what is the meaning of that? A patient will have akathisia. Akathisia is patient is like unrelaxed, like excited, moving around, and they cannot sit quietly. You know, those kind of people who keep moving their body, their legs, their arm. This is the akathisia. If a patient develop akathisia, the first option is to decrease the dose. Okay, what if decreasing the dose didn't work? I can use beta blocker like propranolol. It's more common. What if beta blocker doesn't control? I give benzodiazepine. But the question is it logic to put the patient in benzodiazepine chronically just to help in akathisia? The answer is no. The best option is change him to another thing. Okay, what is the medication that is highly associated with akathisia of the second generation antipsychotic? Which one is mostly associated with akathisia? And there is no clear explanation for that. They noticed that. So if you know the information, tell me. Do you know which second generation antipsychotic is mostly associated with akathisia?
Respiradon?
No. Ziprasidone. Okay, I will say about ziprasidone, I will not say no, but it's not yes, Ziad. I mean, there is another member which is mostly associated with akathisia. It's commonly happen with it.
Dopaminergic.
No, I told you don't try to rationalize it. There is no clear explanation why akathisia is associated with that member. So this one is Olanzapine, Zyprexa. Olanzapine is highly associated with akathisia, and you will find that many patients taking Zyprexa, the Olanzapine, are taking propranolol at the same time just to control akathisia. So Olanzapine is associated with akathisia. We deal with it by giving propranolol. This is OSCE station 2. A patient is coming or is taking antipsychotic. When you look to the history, you will find that he is taking Olanzapine, and he is complaining about moving around and these symptoms. And the doctor is asking for your recommendation. Your recommendation is give propranolol in the dosage of 10 to 40 milligrams. You don't have to remember that, but just keep in mind, akathisia, Olanzapine, treated with propranolol. Okay? Okay. Other symptoms of extrapyramidal symptoms is dystonia. Dystonia is like painful muscle contraction, and if it happens, we give the benzotropine or any other anticholinergic. So, which one is mostly associated with dystonia? Which one? Like the EPS. EPS. Which antipsychotic associated with EPS in the form of dystonia? Hello?
The high potency first generation.
No. We are talking about this. Yes, Palpyridone and Respiradon, because they work on the nigrostriatal pathway, causing this side effect. Okay? Okay. Last thing is tardive dyskinesia. Tardive dyskinesia is involuntary movement of the eye, face, tongue. If it happens to someone, it will be clear. You know, you will find that this person is moving their eye, their tongue, their lips in an abnormal way. This is tardive dyskinesia, and we cannot deal with it by giving something like benzotropine. You have to change the medication, and it's mostly associated with the first generation antipsychotic. So this is why we give the second generation instead. Okay, this is regarding EPS. So to remember EPS again, generally speaking, Respiradon and Palpyridone are associated with EPS due to blockade of D receptor in nigrostriatal pathway. However, Olanzapine cause akathisia for some patient, and we treat it by propranolol, decreasing the dose first or giving propranolol, and in severe case, we can give benzodiazepine, but this is rare to give benzodiazepine. How about pregnancy? Someone is pregnant and she is diagnosed with schizophrenia. What to do, in your opinion? And keep in mind, all antipsychotic have teratogenicity. All antipsychotic, or let's say all antipsychotics have a possibility of teratogenicity because they didn't try it on a pregnant woman. All of the antipsychotic are new medication and you cannot try it on a pregnant woman. So CBT. Okay, Noha. Okay. Yes. So the answer is yes and no. Meaning, if it's a mild schizophrenia, yes, we can give the cognitive behavioral therapy. But we said in the beginning of the lecture that cognitive behavioral therapy is not an effective way of treating schizophrenia. So if it's moderate or severe, at that time, CBT will be of no use, and the doctor has to decide risk-benefit ratio. What is the meaning of that? If the case is severe, the patient might harm herself, and she's pregnant. They might harm the baby. So at that time, no, we will give her medication because the benefit here are more than the risks. But what if the patient is not severe and we can ask someone of the family to take care of her, and you know, at that point, we don't give medication and we follow up and monitor on a daily basis to see how she is doing. This is the meaning of like weighing risk benefit for this patient. Okay, some notes about this topic is Ziprasidone and Lorasidone, when you take them, you need to take them on full stomach after food. That's weird to say about some medication, but this is how it is. Ziprasidone and Lorasidone, you need to take them on full stomach after high calorie meal. So if you have been told in a case or in OSCE that a patient is taking Ziprasidone and there is partial response, the first question that will come to your mind is, do you take it on empty stomach? Do you take it after food? The patient might say, I take it like I take a snack and take Ziprasidone. No, you need to take a heavy meal, then take your medication. Otherwise, its efficacy is less. This is very important about Ziprasidone. And is it stuck on pregnancy? Yeah, because we stop here on pregnancy. This is the last slide. Yes. Yeah, it's stuck on pregnancy because this is the last slide. So this is regarding Ziprasidone and Lorasidone. How to remember that? Zipra, although the spelling is different, Zipra is a kind of animal. So remember that Zipra likes to eat a lot. So because the Zipra likes to eat a lot, Ziprasidone likes to have food to give efficacy, just as a way to remember it. Okay, this is regarding Ziprasidone and Lorasidone. Ziprasidone the patient need to make the ECG test, electrocardiogram every 3 months to 6 months, depending on the doctor decision, because it might cause Q2 prolongation. This is, if you remember the table, when we say that it might affect the cardiovascular system. So this is mainly schizophrenia. Anyone has a question regarding this interesting topic? Hello?
No, thank you, sir.
Is it clear? Anything
Yes, sir.
unclear? Anything confusing?
No, it's good. Thank you.
Okay. However, regarding this topic or any other topic, if anyone needs more clarification, any question, feel free to message me at my first convenience. I will message you back. So we finished it now. What we are going to do now, we will take a break for 10 minutes, 10 minutes only. Go to the washroom, drink coffee, take your medication, whatever. Then I will see you back after 10 minutes for the next topic.